remember that there is HRC, high resolution CT of the chest. There is no magic in it. There are three important things that are important in the technique. One is the high spatial resolution. You should have a thin collimation and high spatial frequency bone reconstruction algorithm. These are the three main features which is different from the routine CT. And this is very important to evaluate the pulmonary interstitium. Now, what we shall go through is how to make a diagnosis based on recognizing the various patterns, based on the distribution and any associated findings. And most important of all is to have a basic knowledge of the clinical history of the patient. So the collimation is usually very thin, 1 to 1.5 millimeters. A high spatial frequency algorithm is used, and generally KV of 120 to 140 is used. And a very high matrix of just the largest available matrix of around 512 to 512 is used. Usually and the window mean and window width depends upon the vendor and the mission. And sometimes the MA is used as 120 to 240. Low dose CT is also preferred when we need to evaluate for follow-up scans. So basically, the HRCT methods are of two types. One is a volumetric acquisition, which is what is routinely being done nowadays with the availability of multi-slice CT, and what we used to do earlier, which was the spaced axial HRCT. The main disadvantage of volumetric HRCT is the additional radiation dose. However, the advantage is it is easier and better interpretation, and we can also evaluate other abnormalities. Now, the general radiation dose from chest CT is usually less than 5 millisievert. And now with the low dose protocols, we can obtain doses of around 2 millisievert as well. For follow-up of high interstitial lung diseases and recently for COVID, a spaced axial HRCT is used with the low dose HRCT protocol. So basically what we shall see in the, before we go on to the abnormalities is knowledge of the anatomy is very important in high resolution CT. So what is the pulmonary interstitium? So it is the network of connective tissue that supports the lung. This can be either axial, which is the peribronchovascular, and the centrilobular. It can, and is the peripheral, involving the subpleural regions. Then the intralobular, that is between the lobules, is very important, and the intralobular interstitium is important. So most of these abnormalities occur in these areas. The secondary pulmonary lobule is the basic unit of the lung in HRCT. By definition, it is irregular or a polygonal in shape. It is about 1 to 2.5 centimeters. It is defined as the smallest unit of the lung, which is surrounded by connective tissue septa. The central structures that are seen are the terminal bronchioles and the centrilobular pulmonary arteries. And it is surrounded by the peripheral structures, which includes the lymphatics, pulmonary veins, and the interstitium. In HRCT, what we can visualize is usually the centrilobular pulmonary artery. Most of the other structures are below the resolution of the HRCT. So this diagram is important for an exam point of view, where you are asked to describe the secondary pulmonary lobule. So this picture is just to show the anatomy of the lobule, where the alveolar are grouped together to form the acini around the terminal airways. So this is the acini, which is grouped together to form which is formed around the terminal airways. These groups of acini form together, cluster, and form the secondary pulmonary lobule. These acini are separated by and supported by the interstitial septum. Basically, in chest radiology or HRCT, there are two basic patterns. One is the alveolar pattern, the other is the interstitial pattern. So we will now concentrate on the interstitial pattern. So what is the alveolar pattern, or the ad space opacification that you see in the chest X-ray or HRCT is when the alveoli or the acini are filled with either fluid or with blood or with the mucus. Then we get this alveolar pattern, which is what is seen in consolidation. In the interstitial pattern, the airway are clear. However, the interstitial abnormalities are there, which can be either reticulation or a mixture of nodules with reticulation, which is called as the reticulonodular pattern. So these are the two basic patterns. In the alveolar pattern, the acini are filled with fluid or mucus. In the interstitial pattern, the interstitium is abnormal, where there may be an interstitial thickening, or there could be intermixed with nodules, which is called as the reticulonodular pattern. So the nodule patterns are of varying types. So moving on to, before we move on to the various patterns, we should recognize what are some of the normal pitfalls or variants. As a beginner, whenever you see a subpleural increased density, this should not be confused with an abnormality or due to an interstitial thickening. This is gravity-dependent atelectasis. And to overcome this, we do a prone CT scan in which we can see the abnormality is seen in the anterior aspect. This is clear. So this should not be mistaken for early interstitial lung disease, especially in patients who have asbestosis, etc. The next important mistake that is made by beginners is this scan. You should not mistake this for a ground glass appearance. So this normal HRCT is taken in end inspiration. This is in an end inspiratory scan where you see the normal lucency of the lung. Now this scan is taken in expiration. How do you recognize an expiratory scan? You look at the trachea. There is a posterior trachea is bowed anteriorly. So this is an expiratory scan where there is increased density. It is seen here. And this should not be confused with the ground glass appearance. So this anterior bowing of the posterior trachea is helpful in identifying this. So what are the basic HRCT patterns? It can be, the basic HRCT patterns may be a reticulation, can be nodular pattern, a ground glass, or a mosaic attenuation and cystic spaces. So let's look at them one by one. So the nodules are multiple small nodules which can be discrete and they may range in diameter from 2 to 10 millimeters. Common causes for the nodules that we see in are tuberculosis, sarcoidosis, and Kohlwerker's pneumoconiosis or any granulomatous diseases, metastasis, hypersensitivity pneumonitis, and bronchiolitis. It can also be seen in other rare conditions like amyloid, panbronchiolitis, and vasculitis. Based on the distribution of the nodules, they can be of three types. One is the centrilobular nodules, where we can see which is seen nodules which is seen around the centrilobular structures. So these are tiny nodules just seen around the centrilobular structure. These are centrilobular nodules. Perilymphatic nodules, these are seen not only along the vessels in the centrilobular areas, they can also seen in the periphery of the secondary pulmonary lobule. So these are called as perilymphatic nodules. Random nodules involve both centrilobular and the perilymphatic regions, where we see nodules in the periphery as well as in the centrilobular areas. So these are the three major types of nodules. The perilymphatic nodules are commonly seen with sarcoidosis, also seen with silicosis and lymphangitic spread of carcinomas. So here you can see it is seen around the perilymphatic and also you are seeing around the peripheral regions. So this is a perilymphatic distribution of nodules. So typically in sarcoidosis, you can see the peribronchovascular and interstitium and nodules around the, which is seen along the peribronchovascular areas. And silicosis also you get nodules, which is more along the pleural surfaces and also in a centrilobular location. These are called as bronchiolocentric distribution, which is seen in silicosis. And to differentiate, additional finding is the history of exposure to silica is important. So typically in sarcoid, you may get bilateral symmetric hilar lymphadenopathy, which can be calcified. And this is the typical appearance of peribronchovascular nodules and peribronchovascular interstitial thickening, which is evident in sarcoidosis. The lymph node calcifications can be typically bilateral symmetric and hilar distribution. It can also be seen in the peribronchovascular areas in sarcoidosis. The nodules in silicosis may be seen more in the pleural distribution, and also we can see bilateral confluent masses which can be seen with silicosis. These are suggestive of progressive massive fibrosis, and multiple other nodules are seen along the peribronchovascular interstitium. Typically, the random distribution of nodules is seen with miliary tuberculosis, which is also called as a miliary pattern, which can be seen with tuberculosis or fungal distribution and hematogenous metastasis. By definition, the miliary pattern is defined as tiny uniform sized nodules, just 1 to 3 millimeters in size in a bilateral symmetric distribution. So this is the classic appearance of a miliary tuberculosis, which is uniform sized and homogeneously distributed. On the other hand, miliary metastasis can be seen, especially with thyroid malignancy or breast CA. You get again multiple random distribution of nodules with slightly ununiform size, and there may be a feeding vessel sign which can be seen in case of hematogenous metastasis. So this is a patient who has a small cavities with bilateral uniform distribution of nodules, which is a typical miliary tuberculosis pattern. The centrilobular distribution of nodules is mainly limited to the centrilobular region with sparing of the pleural surface. So basically, this occurs with diseases that involve the centrilobular bronchiole or the centrilobular artery, and which can be seen with either mucoid impaction or peribronchovascular inflammation or fibrosis. So this is the distribution of the nodules around the peribronchovascular areas. And whenever centrilobular nodules are seen, try to look for the tree-in-bud appearance. So the tree-in-bud appearance is these branching structures which are seen around the peribronchial areas. Whenever tree-in-bud nodules are seen, it indicates its endobronchial spread of infection, which can be seen with tuberculosis or bronchopneumonia. And it can also be seen due to mucus retention. Sometimes, rarely, endobronchial malignancies can also produce this appearance. And without tree-in-bud appearance, reflects a bronchial infection, which can be seen in respiratory bronchiolitis or hypersensitivity pneumonitis. So whenever alveoli are involved, it reflects an alveolitis. Whenever centrilobular nodules are seen, it reflects a bronchiolitis, which can be infectious or inflammatory or due to other causes. So look at this HRCT here, and what is the pattern that is seen here? You are seeing multiple centrilobular nodules, also peribronchovascular thickening, with few areas showing a tree-in-bud appearance. So this is the typical centrilobular nodules pattern with tree-in-bud appearance. So this was due to a peribronchovascular thickening, and there was mucus plugging, which was involving the left lower lobe bronchus. Again, another patient who presented with cough and dyspnea, and they came for HRCT, and typical appearance of centrilobular nodules with few areas showing tree-in-bud appearance. And the mediastinal window, so we saw this dilatation of the esophagus, and this is the 3D volume image that shows a dilated esophagus. No obvious wall thickening was evident. So this was a case of achalasia cardia, and the reason for the bronchiolitis in this case is an aspiration. So aspiration bronchiolitis has to be suspected whenever the patient is having an achalasia cardia. And it is important that we look at the mediastinal window as well. So we saw three basic patterns of nodules: distribution in centrilobular, perilymphatic, and random nodular pattern. So moving on to the next pattern in HRCT is the reticular pattern. The reticular pattern can be either of interlobular septal thickening, or it can be intralobular septal thickening, or the subpleural interstitium can be involved, or they can present as parenchymal bands. So what is the significance of a reticular pattern? It reflects thickening of the interstitial fibers by either fluid or fibrous tissue or cell infiltration. So typically where there is a reticular pattern can be seen with either pulmonary edema, which is smooth lymphatic spread of carcinomas, or alveolar proteinosis, idiopathic pulmonary fibrosis, and other collagen vascular diseases and drug-related conditions and amyloidosis. Reticulation may be an associated finding in other conditions like in sarcoidosis, where you may also get lymphadenopathies, pneumoconiasis, and pulmonary hemorrhage and asbestosis. So what is interlobular septal thickening? We saw what is a secondary pulmonary lobule. By interlobular septal thickening is thickening involving the interlobular regions, where you can identify the secondary pulmonary lobule. So we can see this smooth thickening of the interlobular septa in these areas. So where clearly visible interlobular septa are outlining the secondary pulmonary lobule. This is smooth. An intralobular septal thickening involves within the lobule, and here we can see there is a fine network of lines that is seen within the lobules. The third pattern is the classic honeycombing appearance, where you get multiple tiny cystic areas in several layers, and these are about 3 to 10 millimeters in diameters and thick walls. So this is how they differentiate between a honeycombing, and this is an intralobular septal thickening. This is interlobular septal thickening. So the interlobular septal thickening can be due to various causes. It may be due to thickening by fluid, blood, or fibrosis. The pulmonary veins may be dilated. So what is seen is this can be seen in association with other findings. Whenever it is seen as a separate or isolated finding, it has a limited significance. So this is the thickening may be either smooth, nodular, or irregular. So this is the secondary pulmonary lobule with thickening, and this shows the nodular thickening of the interlobular septa. This is an irregular thickening. This smooth thickening is seen when fluid is accumulating, as in case of early pulmonary edema, A nodular thickening of the interlobular septa, which is seen here, which can be seen with sarcoidosis, and irregular thickening, which can be seen with either lymphangitis or with fibrosing lung diseases. So the thickening, smooth thickening can be seen with pulmonary edema or even pulmonary hemorrhage, where there is a smooth thickening of the interlobular septa, or with pulmonary alveolar proteinosis, when it is intermixed with areas of ground glass appearance, which is called as the crazy paving appearance. So this is the typical crazy paving appearance, which is seen in pulmonary alveolar proteinosis. So this is thickening of the interlobular septa, which is smooth. Associated, you get bilateral patchy ground glass ossification. Pleural effusion is also seen. And it is a perihilar gravitational distribution. So all these features are consistent with pulmonary edema due to a cardiac failure or a cardiogenic pulmonary edema. And we can see the bilateral pleural effusion here. So always correlate with associated findings and come to a conclusion. The nodular thickening may be seen with the lymphatic spread of carcinoma, or it can be seen with sarcoidosis. So in lymphangitic carcinomatosa, the thickening could be smooth or nodular. They may be found having either a focal or an asymmetric distribution. So there is a thickening of both the interlobular and interlobular axial interstitium in case of lymphangitis carcinomatosa. And fibrosing lung diseases also can cause interlobular septal thickening, which can be resulting either due to sarcoid or due to chronic hypersensitivity pneumonitis. And this is the thickening, which is an interlobular septal thickening, which is relatively irregular. So what is honeycombing or a honeycombing sign is like this is multiple cluster of cystic air spaces, which have thick fibrous walls, and these are lined by bronchial epithelium. So this is the classic appearance. This is an on-like appearance where you see cluster of tiny cystic spaces with thick walls with multiple layers. Whenever classic appearance involving the bilateral lower lobes, subpleural regions, lower lobes is there, then this pattern is called as a usual interstitial pneumonia pattern. And idiopathic pulmonary fibrosis is the most likely diagnosis when other known disease is absent. So this is classic appearance of honeycombing, and this has to be differentiated from paraseptal emphysema. So in paraseptal emphysema, you see the cystic air spaces, which is usually of a single layer. And interlobular septal thickening should not be confused with honeycombing. The difference is you see fine cystic spaces in multiple layers with thick walls. So here you get the cystic areas with the walls are relatively fine and thin. And this is interlobular septal thickening. So we should not always overcall honeycombing. So the classic findings in usual interstitial pneumonia pattern is areas of honeycombing with reticular opacities. They are peripheral basal distribution in the subpleural regions, predominantly involving the lower lobes. And how do you differentiate usual interstitial pneumonia pattern from a non-specific interstitial pneumonia pattern? Ground glassing is more common in NSIPs with the related subpleural sparring, which is common in NSIP pattern. So according to various criteria are there to say that this UIP pattern. So to say a definite UIP pattern, we have to look at its basal and peripheral predominance, honeycombing, and there may be a traction bronchiectasis. We report consistent with UIP pattern when there is a minimal ground glassing, basal and peripheral reticulation with minimal or no honeycombing. An alternative diagnosis suggested when there is only predominant ground glass or nodules or cysts with no honeycombing. And now recently in the 2013 version by the American Thoracic Society, where they have said that all four features have to be present to say in UIP pattern, which is subpleural basal predominance, reticular abnormalities, honeycombing with or without traction bronchiectasis, and some features have to be absent. So these features that have to be absent is upper or mid-lung predominance, extensive ground glassing has to be absent, micronodules, discrete cysts, and diffuse mosaic attenuation and air trapping has to be absent. To say it is a UIP pattern. We say it is possible UIP pattern when it is subpleural and basal predominant and absence of features just inconsistent with UIP pattern. So this is serial axial CT sections that shows subpleural basal predominance, multiple honeycombing areas, which is seen predominantly in the subpleural and basal regions. So, and in the absence of other abnormalities, we call it as idiopathic pulmonary fibrosis. So this patient was evaluated and other causes were ruled out. And again, another patient where we can see a basal reticulation is there, although there is no typical multiple classic honeycombing appearance. The distribution is basal, and so a pattern may be suggested of an UIP pattern can be suggested. Moving on to intralobular interstitial thickening, which is thickening of the interstitium at a sublobular level. It can be either isolated or it could be associated with ground glassing, which is called as the crazy paving pattern. So these are fine linear structures which is below the resolution of HRCT. Intralobular interstitial thickening is seen with NSIP pattern, where there is patchy areas of ground glass opacification with a subpleural distribution, predominantly in the mid or lower zone, and there may be a subpleural sparing as well. The reticular pattern may be superposed on the ground glass, which is called as a crazy paving appearance. Traction bronchiectasis can be seen. Typically, honeycombing is very uncommon in NSIP pattern. The NSIP pattern can be either cellular or can be fibrotic. In the cellular pattern, again, you get predominant ground glass opacity involving the lower lungs with the subpleural sparing. To subpleural sparing is seen. Follow-up of this patient some years later revealed reticulation with the gradual disappearance of the ground glassing with significant peribronchoscopal reticulation and traction bronchiectasis. So this is a fibrotic type of NSIP. To sum up the difference between the typical UIP pattern and the NSIP, honeycombing basal predominance in UIP, NSIP reticulation, basal reticulation with related to subpleural sparing will be seen. So this is the differences which is seen between the NSIP and the UIP. The subpleural sparing is seen here. Here predominantly honeycombing with basal subpleural reticulation. So HRCT in the areas of reticulation can also be used to assess not only the diagnosis, but can also be used to assess the progression. Most of the time we receive HRCTs by the rheumatologist for follow-up of these patients' interstitial lung disease after the usage of drugs. So it has prognostic value and it can be used to follow the prognosis and to detect complications also like infections or acute exacerbation or other abnormalities. So this was a patient where we can see some areas of subpleural increased densities, and after few months we see this basal progression to slight honeycombing in these areas. So there are several causes for fibrotic lung disease that can mimic idiopathic pulmonary fibrosis on HRCT. We saw a few of them. It can be due to an NSIP pattern or a fibrotic hypersensitivity pneumonitis. It can be due to collagen vascular diseases, or it can be due to aspergillosis, sarcoidosis. Typically, a few features may be used to differentiate based on the basal distribution. For example, fibrotic hypersensitivity pneumonitis, it has a mid or upper lung distribution. Subpleural sparing is seen in NSIP with more of honeycombing. And collagen vascular disease, it's difficult connective tissue disease. It's difficult to differentiate sometimes from idiopathic pulmonary fibrosis. And there may be a multi-organ involvement such as involvement of the esophagus, etc. In asbestosis, pleural calcified pleural plaques may be evident. So this is just what I can see. There is a subpleural reticulation involving the lower lobes predominantly with a basal distribution. And there is a relatively, you can see the esophagus is relatively dilated. So this is a clue. This is in exams, they usually keep this where we see the typical basal reticulation or honeycombing with the dilated esophagus. Then the diagnosis is scleroderma. So to pick up scleroderma in HRCT is look at the patellus lower esophagus or the dilated lower esophagus in association with typical honeycombing or even basal reticulation. So this is honeycombing, which is more evident in the upper lobes. You can see it. So this rules out, this is an UIP pattern. This rules out, this is not due to a usual interstitial pneumonia pattern. This reflects it's a fibrotic lung disease, which is probably due to a hypersensitivity pneumonitis. So the mimics of usual interstitial pneumonia pattern may be due to fibrosing lung diseases, or it could be due to fibrosing sarcoid, asbestosis, and drug reactions. So this was a case of a chronic hypersensitivity pneumonitis. So this just to summarize the causes of honeycombing. Whenever honeycombing is seen in upper lobes, then it can be due to chronic hypersensitivity pneumonitis or even ankylosing spondylitis, Langerhans histiocytosis, or due to radiation therapy in the upper lobes, involving the upper lobes, in-stage sarcoid. Honeycombing involving the lower lobes, typically seen with usual interstitial pneumonia pattern, or with sometimes with drugs, or NSIP pattern, which is related to scleroderma, rheumatoid arthritis. If honeycombing is unilateral, then it may be due to unilateral aspiration or pulmonary artery sarcomas. Recognize the ancillary findings like dilated esophagus, which is seen in scleroderma, syndesmophytes, which can be seen in ankylosing spondylitis, pleural plaques, which is seen in asbestosis. So this is a patient was taking drugs for rheumatoid arthritis, and patient developed basal reticulation. So this is due to a drug-induced interstitial lung disease. And idiopathic interstitial pneumonia pattern can also be, various causes are there due to chronic fibrosing, idiopathic interstitial pneumonia pattern, which is typically seen with idiopathic pulmonary fibrosis. And the smoking-related pattern can be seen with respiratory bronchiolitis associated lung disease, in which other abnormalities like mosaic attenuation may also be evident. And it can also be seen with cryptogenic organizing pneumonias, and rarely it can be seen with lymphoid interstitial pneumonias. And in lymphocytic interstitial pneumonia, typically it has a basal, again middle or lower lung predominance. It can be seen associated with systemic conditions or autoimmune conditions, typically seen with women in the 5th decade. There may be patchy ground glassing with centrilobular nodules and air trapping with a mid to lower lobe predominance. So we have just covered about the two patterns, the nodular pattern and the reticular pattern. We shall now proceed to the next pattern, which is the ground glass opacification. So what is ground glass opacification? It is actually a non-specific finding that reflects abnormalities which is not evident. The term ground glass is not used in chest X-ray, it is basically used in HRCT. It reflects abnormalities, which is a volume averaging of abnormalities which cannot be completely seen with the naked eye and which cannot be completely addressed by HRCT. Typically, there is a hazy airspace opacification with preserved bronchovascular structures. In consolidation, there is a solid airspace opacification. So what is the significance of ground glass opacification? Generally, ground glass is interpreted as active and it is reversible if there is no associated fibrotic changes in the lung. If there is an associated lung fibrosis, then the biopsy will be directed towards the ground glass opacified areas. So whenever the ground glass opacification is superimposed with reticulation and with interlobular and interlobular septal thickening, that is called as a crazy paving appearance. Expiratory HRCT images are very useful whenever there is a ground glass opacification for differential diagnosis. So whenever there is a lobular air trapping and expiratory air trapping, this is more associated with hypersensitivity pneumonitis than idiopathic pulmonary fibrosis. So it is, as a protocol, it is advisable to use expiratory HRCT in patients with usual interstitial pneumonia pattern IPF to rule out other causes like hypersensitivity pneumonitis or tissue diseases. So what are the patterns of ground glass opacification? They can be seen in various patterns. They may be diffuse, or there can be a halo-like ground glass around a nodule. It can be focal ground glass, can be a patchy ground glassing, or it can be a peripheral ground glass, subpleural ground glass, which can be seen with the eosinophilic pneumonias and more recently with COVID pneumonias. It could be bronchovascular. So these are the various patterns of ground glass opacification. Let us see a few of these cases. In the diffuse causes, it can be due to pulmonary edema or pulmonary hemorrhage or ARDS. It can also be seen with extrinsic allergic alveolitis or due to infections. So this is ground glass opacification, which can be seen in a pneumocystitis carinii pneumonia, and where we can you can see the black bronchus-like appearance through the ground glass areas. It can also be seen in pulmonary alveolar proteinosis, which is due to intraalveolar accumulation of the lipoproteinous materials, where you see diffuse ground glass opacifications and consolidations with septal thickening and also the crazy paving appearance. There is reticulation in a background of ground glass opacification in the case of pulmonary alveolar proteinosis. Hypersensitivity pneumonitis can be either acute, subacute, or chronic. In the acute cases, ground glass opacifications can occur, and these are usually can be multifocal or patchy in geographic areas, localized more in the upper areas. So whenever typical clinical history would be evident with exposure to any organic antigen. Diffuse pulmonary hemorrhage disorders can also cause diffuse ground glass opacification, where it can be either due to this case of Goodpasture syndrome with ground glass opacification, and it may be associated with septal thickening, which can be seen with pulmonary hemosiderosis. And we have also seen that ground glass opacification can also be seen in association with non-specific interstitial pneumonias. Systemic lupus erythematosus can present with pulmonary hemorrhage, where you get this diffuse ground glass-like appearance. Infections can cause ground glass appearance, and various causes of bacterial or viral pneumonia can cause. But now we know the commonest cause of ground glass opacification is the COVID pneumonias, and this is typical appearance of multifocal subpleural distributions and peribronchoscopal distributions of ground glass opacification, which was seen in the case of COVID pneumonia positive patient. And we do multiplanar reconstruction imaging, where we can assess the severity and use the severity score. And this patient was followed up. This patient was treated and came back. And after the follow-up, we see that there is peribronchovascular areas of ground glassing and consolidation, and subpleural changes, which are reflecting peribronchovascular thickening in these areas. So this is another COVID pneumonia positive patient, where you can see a consolidation and surrounding that there is ground glass-like appearance. And this is the unilateral distribution, the predominant unilateral distribution involving predominantly the right lobe in a COVID pneumonia patient. So I would also like to stress upon the importance of this sequence. So we routinely do a load the sequences into the MPR images. This is called as a minimum intensity projection. In the minimum intensity projection, we can see the trachea and the bronchi, and also we can also observe the reticulation that is seen here in this patient. There is a consolidation and the ground glassing, which is more seen, and also we can see the peribronchovascular thickening here in the minimum intensity projection images. So two images in the post-processing, which is important, is minimum intensity projection. The other is we can use also the MIP, the maximum intensity projection images, where we can use to differentiate nodules from tiny vascular vessel passing, which can mimic nodules in axial sections. So you can load it into 3D MPR and differentiate where the nodules are discrete in the coronal and sagittal images, whereas the vascular structures may follow the vessels in the coronal and sagittal images. And moving on to the next spectrum of ground glass, which is focal. The focal ground glass opacities may be benign, which can be seen with focal inflammation or focal atelectasis. An intermediate appearance grade, which can be seen with focal interstitial fibrosis or atypical adenomatous hyperplasias or limited organizing pneumonias. Neoplastic may be due to minimally invasive adenocarcinomas or due to lymphoproliferative diseases. So these are few examples. This is focal inflammatory, where you can see a focal solid ground glass opacities. Here, you can see this is an atypical adenomatous hyperplasia. This is a focal solid-like appearance, and this is an example of a minimal invasive adenocarcinoma, which is previously called as bronchial carcinoma, which is a focal ground glass, which is again subsolid appearance. So we saw some causes of diffuse ground glass appearance and a few causes of focal ground glass appearance. Now let's move on to another pattern, which is called as the mosaic attenuation. So what is mosaic attenuation? These are variable areas of lung attenuation, which can be seen in lobular or multilobular distributions. And these are due to diseases which are demarcated by the secondary pulmonary lobule. And sometimes it's difficult to differentiate what is ground glassing, what is mosaic attenuation. So how do you differentiate both? For this, you have to look at the attenuation pattern of the lung and look at the centrilobular vessels. So this is, we see this both appear the same, but look at the vessels here. The vessel number and size are, this is the normal lung, and this is a part of the abnormal lung. The vessel caliber and size are relatively reduced in this portion of the normal lung, of this lung. Then this is called as a mosaic attenuation. So whenever the vessel caliber is reduced in areas of low attenuation compared to a relatively normal looking lung, then it is known as a mosaic attenuation. Whereas in ground glassing, if you see compared to both the low attenuating and the high attenuating areas, the vessel caliber is the same. Then this is called as a ground glassing appearance. So look at the vessel caliber. It's important to recognize the reduction in vessel caliber in case of a mosaic attenuation. The next important thing to differentiate helpful in mosaic attenuation and to differentiate it is an expiratory HRCT. In expiratory HRCT, you have to look for air trapping. So you can see here parts of the low attenuating areas where the vessel caliber is small here. And with an expiratory CT scan, the areas of low attenuation are exaggerated. So this is an expiratory air trapping which reflects a small airway disease. Mosaic attenuation can also be due to small vessel disease, and expiratory air trapping is used to differentiate a small airway disease from a small vessel disease. So what are the causes of mosaic attenuation? It can be due to small airway disease, it can be reversible. This can be seen in bronchial asthma, or it can be fixed, which is seen in obliterative bronchiolitis. It can be vascular due to vascular causes, due to pulmonary hypertension or pulmonary thromboembolism. And the third is the primary parenchymal lung disease, which is consolidation, which is what we have seen earlier. So the small airway disease causes can be due to asthma, or it can be fixed, which is seen in constrictive bronchiolitis or respiratory bronchiolitis. Other causes may be Swire-James syndrome, bronchiectasis, or allergic bronchopulmonary aspergillosis. So the hallmarks of small airway disease is that expiratory air trapping is evident, and mosaic attenuation is seen at a lobular or a multilobular level. So when you do expiratory, so you can see here, this is the vessel in areas of increased density, and these are low attenuated areas where the vessel caliber is reduced. So this is mosaic attenuation. And with expiration, air trapping is evident. So this reflects bronchiolitis. So the bronchiolitis, respiratory bronchiolitis, can also be seen in healthy smokers. So this is an inspiration in a healthy smoker with slight inhomogeneous lung attenuation is evident. But with expiration, you see multifocal areas of air trapping is seen here in the expiratory, where you see the low attenuation areas compared to the areas which show increased density. The vessel caliber, compare the vessel caliber here, they are reduced. So this reflects mosaic attenuation with expiratory air trapping, which reflects bronchiolitis. And another case with constrictive bronchiolitis or obliterative bronchiolitis, expiratory HRCT demonstrates expiratory air trapping. So we have to be clear about this. Do not mistake this for ground glass appearance. Whenever you see inhomogeneous lung attenuation, compare the vessel caliber in these areas with abnormal low attenuating areas. If the caliber is reduced, then this area is abnormal. So this is a patient with this cylindrical bronchiectasis with inhomogeneous lung attenuation, and mosaic attenuation is seen in this patient with bronchiectasis. This is a patient with bronchial asthma where there is relative thickening and dilatation of the bronchi, and inhomogeneous lung attenuation is seen. With the expiratory CT, we get expiratory air trapping, which is seen with bronchial asthma. In patients with systemic sclerosis, constrictive bronchiolitis can occur. And in these patients, again, expiratory HRCT is helpful. Whenever inhomogeneous lung attenuation is seen, or with mosaic attenuation is seen in patients who come for evaluation, then we have to do an expiratory HRCT. In expiratory HRCT, we look at the expiratory air trapping, and this reflects a constrictive bronchiolitis in a patient with systemic sclerosis. So this is serial sections of the lung parenchyma, where you can see there is, compared to the there is an asymmetry of the lung. The lung attenuation appears to be relatively decreased in the left side, and some patchy areas of mosaic attenuation are seen in the right lung parenchyma. And there are various causes for such an appearance. So we can see, if you see here, focal areas of mosaic attenuation are seen in the right lung, whereas diffuse low attenuation is seen in the left lung. And this is an example of a minimum intensity projection. And you can see the multifocal areas of low attenuation in the right lung. The left lung, on the other hand, shows diffuse low attenuation. So the various causes are there for the diffuse low attenuation. In the chest X-ray, this will be seen as a hyperlucent left hemithorax, and so many causes are there for the hyperlucent left hemithorax. And this patient was evaluated, had an expiratory air trapping, and CT pulmonary angiogram was done. And this is the volume rendered image that shows the non-main pulmonary artery. This is the right main pulmonary artery, which is normal. However, you can see there is a pulmonary artery hyperplasia involving the left pulmonary artery. So this was a pulmonary artery hyperplasia with diffuse low attenuation. So what is this abnormality, or what will you suspect in this patient in a child who presents with recurrent respiratory infections? So the diagnosis would be a case of a Swyer-James syndrome or a McLeod syndrome. So this is basically again a bronchiolitis which is presenting with recurrent URIs in children, and you can see diffuse low attenuation of the lung with pulmonary hypoplasia in these patients. So we saw some causes of mosaic attenuation with expiratory air trapping, which is basically due to small airway disease. If mosaic attenuation is due to vascular lung disease, then in expiratory HRCT, there is no expiratory air trapping. You may also see associated findings like eccentric filling defects in the pulmonary artery or branches. Main pulmonary artery could be enlarged in pulmonary arterial hypertension, or there may be pruning or stenosis of the pulmonary arteries. So this is a patient who had pulmonary artery embolism. You can see a saddle thrombus involving the bifurcation. And these are diffuse areas of air trapping, diffuse area of mosaic attenuation with no significant air trapping. Why do you say there is no air trapping? Look at the vessel caliber in this area of low attenuation. This is actually almost the same as that of the abnormal one. So this is due to a pulmonary thromboembolism causing mosaic attenuation. And this is again an inspiratory scan compared with an expiratory scan here. And again, no areas of air trapping are evident in these patients in chronic thromboembolic disease. So here you can see the significantly dilated main pulmonary artery, which is more than 37 millimeters. And we should know that the dilatation of the main pulmonary arteries. So the typical main pulmonary artery may be up to a limit of 29 millimeters is normal. And more than 29 millimeters is sensitive for pulmonary arterial hypertension. Whenever it is more than 34 millimeters, it is said to be specific for pulmonary arterial hypertension. And here you can see that diffuse inhomogeneous lung attenuation with mosaic attenuation of the lung, which is due to a pulmonary arterial hypertension. To summarize, mosaic attenuation, it can be due to either airway disease or a vascular disease. If there is air trapping, then it reflects an airway disease. If there is no air trapping in expiratory disease, then it is due to a vascular disease. So here you can see that whenever there is air trapping with expiration, it is due to airway disease. And here there is no air trapping. The vessel caliber, both the increased density areas and attenuation areas are of normal caliber. So we saw the mosaic attenuation may be due to small airway disease, due to asthma, or it can be due to obliterative bronchiolitis. Vascular causes we saw, and primary pulmonary parenchymal disease, which can be seen in infections, or it can be due to non-infectious causes. Basically, this is characterized by either a ground glass appearance or consolidation, which may be due to filling of the air spaces with fluid, cells, or fibrosis. So again, just recap, we saw that in pneumocystis carinii pneumonia, there may be ground glass appearance, and it can be multifocal or patchy. This diffuse ground glass can also be seen in consolidation to distress syndrome, where there is a gravity dependent will be there, gravity dependence will be there, and the consolidation will be in a craniocaudal direction. So you can see here consolidation with air bronchograms. So the algorithm for mosaic attenuation is vessel caliber and number is similar in high and low attenuation areas, then it is due to a primary parenchymal disease. Vessel caliber and number is decreased in low attenuation due to respiratory CT. Air trapping is seen, small airway disease. No air trapping, then it is due to a vascular disease. So I hope that all of you are clear with the mosaic attenuation pattern and how to differentiate it or not to confuse it with ground glass opacification. Moving on to the final pattern, which is cystic air spaces. So the cystic air spaces, various causes are there. It can be due to Langerhans cell histiocytosis, which is multiple and diffuse cysts will be there. They are of variable sizes and shapes with thin wall. This is a multiple tiny cystic spaces, which is seen here predominantly, which is seen in the upper lobes. So it can also be centrilobular emphysema, which are centrilobular lucencies without distinct walls. There may be a central dot within the lucency, which represents the branch of the pulmonary artery. So this is an example of a centrilobular emphysema with central dot appearance. Honeycombing we saw already, where there is air-filled spaces with thick walls, which is clustered in subpleural regions, classic honeycombing appearance. Cystic bronchiectasis, where it is tubular rather than spherical dimensions, and multiple cystic spaces, which may lead on to the bronchi, the main bronchus. So these are the important causes of cystic ad spaces that has to be remembered. So whenever cysts are seen, some clues to the diagnosis. When cysts are seen in the upper lobe, it can be due to centroacinoid emphysema, Langerhans cell histiocytosis, or PCP pneumonia. Honeycombing, which is seen in the lower zone, we saw it is due to UIP pattern, or it can be seen in the other patterns like lymphangioliomatosis. Cysts with ground glass opacifications can be seen with the pneumocystic disc pneumonia or subacute hypersensitivity pneumonitis. Cysts in association with centrilobar nodules will be seen with Langerhans cell histiocytosis or with the lymphoid interstitial pneumonia and even with subacute hypersensitivity pneumonitis. Whenever cysts are seen with hyperinflation or trapping, then it is maybe due to emphysema or lymphangioliomatosis. Cysts with smoking history, again, you have to think of emphysema or with LCH. And cysts with pleural effusion, it can be seen with either a lymphoid interstitial pneumonia or due to lymphangioliomatosis. Cystic expiration will be seen in case of honeycombing. So this is a typical appearance of Langerhans cell histiocytosis, where there is cysts of varying sizes and reticulonodal opacities predominantly involving the upper lobe. So emphysema can be of various patterns. It can be centrilobular or panlobular or paracental. The typical centrilobular emphysema usually occupies the upper zone. These are centrilobular lucencies. Panlobular emphysema usually involves the lower lung predominant, and there are confluent areas of hyperlucency that can span one or more lobules. This is the typical paraseptal emphysema, which involves mainly the periphery of the lung parenchyma. So we have seen some common patterns. There are 4 main patterns, which is the first we saw about the nodular pattern. Nodular pattern can be either random or centrilobular or perilymphatic. We saw the reticulation, which can be due to interlobular septal thickening, which may be smooth, irregular, or nodular. The intralobular septal thickening, which can be differentiated based on the distribution associated abnormalities. We saw ground glass, which is commonly diffuse, but can also be focal. And finally, we saw the mosaic attenuation patterns and the other pattern, which is the cystic ad spaces. I shall now show some cases and the patterns. So here we can see this, just to look at the pattern, we see that involvement predominantly of the lower lobes. There is a subpleural spine, and you can see just note down the pattern. You can see some reticulation is seen, which patchy ground glassing. This is the pattern. There may be several causes, and it's difficult to differentiate. So this patient presented with dyspnea, and this patient was presented to the ER actually with dyspnea, acute breathlessness, and mediastinum window showed, what is this? There is an air around it. So there was a mediastinum. And history of this patient revealed that this patient had consumed poison. And this was actually a paraquat poisoning. This paraquat poisoning resulted in these changes. And after 1 week, the patient did not improve. We saw increase in the ground glass opacifications with subpleural interstitial thickening. And this is another case that we had of paraquat poisoning. Again, we see subpleural ground glass, subpleural reticulation. And I wish to highlight all these changes, although this is very rare, is that we have to always elicit the clinical history and the type of presentation of the patient, whether it is acute presentation and what is the clinical history. So this will clinch diagnosis in this patient who mimics actually a fibrotic lung disease. So again and again, wish to stress the importance of history and do not report HRCT chest blindly without any history background or any other clinical detail. So basically, what is paraquat? It is a herbicide that is used in agriculture, which is highly toxic. It basically causes bilateral alveolitis, which is chemical induced and may present as an acute respiratory distress syndrome. And it can, recovery of patients may result in fibrosis, which can cause respiratory problems. So we shall just now see some recap of these patterns. So you can just or have a recap or just recognize these abnormalities. So what is this pattern? This is a honeycombing, basal, predominant, subpleural reticulation. And this is a typical usual interstitial pneumonia pattern. Here you can see multiple cystic ad spaces here, and some areas of low attenuation of the lung is evident, and the involvement of the lower lobes is predominant. This is a panacinaire emphysema. So the typical exam spotter, multiple uniform-sized nodules, cluster of nodules. This is classic miliary pattern, which is seen with miliary tuberculosis. So what is this pattern? This is a fibrotic lung disease mimicker, and you can see some peribronchoascular thickening with confluent masses, and the additional clue is the presence of the calcifications, bilateral hilar lymph nodal calcifications, and large chunky calcification hilar lymph node. So this is silicosis with progressive massive fibrosis involving both sides. So what is the pattern? The pattern is diffuse ground glass opacification. In addition, we find there are multiple cystic spaces, which is seen here. So the diagnosis would be a pneumocystitis carinii pneumonia. Now, what is important to know is this is ground glass opacification with nematoceles. And earlier it was called pneumocystis carinii pneumonia, but now the causative organisms has been reclassified as pneumocystis jirovecii, since the term refers to a species that is found in rats, whereas the jirovecii is found in the human isolate. So again, what is the pattern here? Multifocal ground glass opacities are evident, involving scattered through both lung parenchyma. This patient actually presented with complaints of abdominal pain and chest pain. So in the mediastinum window, you see bilateral pleural effusions are there. And in the abdominal window, you can see just a focal enlargement of the pancreas. So this patient had pancreatitis, acute pancreatitis. So in a patient with acute pancreatitis, whenever you see multifocal ground glass opacities, then we have to suspect a possibility of a fat embolism. So the multiple ground glass opacities was due to fat embolism. Also, this patient also developed severe headache and multiple areas of restricted diffusion in the brain, which is due to the embolia again. So again, what is this pattern? There is peribronchoascular interstitial thickening and some peribronchoascular nodules. There is peribronchoascular consolidation. So this is a type of an organizing pneumonia pattern. And this cause for the organizing pneumonia pattern in this patient was found to be a pseudomonas, where there is an interspersion with bronchiectasis as well. So predominantly subpleural. Usually the organizing pneumonia pattern may be subpleural or peribronchoascular distribution. In pseudomonas, they usually have a perilobular pattern, which can be seen in about 60% of these cases. So what is your take-home message is that there is no magic in HRCT of the chest. Recognize the basic patterns of HRCT, which may be the nodules, reticulation, ground glass opacities, and mosaic attenuation. Always correlate with clinical background. Remember, do additional findings like do an expiratory HRCT, which may be helpful to differentiate various causes of mosaic attenuation. It can also be helpful to differentiate UIP from other causes of expiratory air trapping. Thank you all for patiently listening.
Thank you, Dr. Babu, for a very nice and lucid talk on common HRCT patterns. I'm sure it must have benefited the residents a lot. There are few questions. I think we can take them. So I'll start from the most recent questions. There is a question, Dr. Babu. Recap 2 is not alveolar microlithiasis, which you showed probably was miliary tuberculosis. So,
yeah. Just is the screen visible?
Yes, it has to go on a slideshow now.
Yeah. So this is, as I mentioned before, this is tiny uniform-sized nodules. Multiple tiny nodules are there, uniform-sized, and the patient presentation was also a known case of pulmonary tuberculosis. Already was evaluated for other causes of tuberculosis, and this patient incidentally came for us MRI brain, and patient had multiple tuberculomas in the brain. And the patient was also subject to HRCT, in which recognized these abnormalities. And these are tiny uniform-sized nodules, which is bilateral and symmetric. So this pattern, which is classical of a miliary tubercular pattern, tuberculosis. Whenever you see this pattern, you can always consider miliary tuberculosis. And there may be superadded other patchy focal ground glass opacifications, which may probably mislead. But,
and these nodules usually have a subsolid density. Whereas in
Yes,
microlithiasis, they are very dense actually.
yes,
Yes, that's what I'm also interested in saying.
Yeah.
The nodules are maybe a little bit more larger in size,
More denser,
more
and you can see
denser,
the black pleura.
and also black pleural sign.
Yeah,
So all
black
these things
pleura
are for
inside. Yeah.
pulmonary
Yeah.
microlithiasis.
yes,
Dr.
sir.
Babu, the second question is why an expiratory scan is needed? Why is it done? So you had explained it very nicely, but maybe the attendee has some confusion. The question is
I'll
why
try to.
Yeah.
Yeah, the expiratory scan is HRCT is basically done for two main purposes. One is evaluation of mosaic attenuation.
Correct.
So the mosaic attenuation, one is it can be due to either an airway disease or it can be due to a vascular disease. So when you do expiratory airway disease, when you do expiratory HRCT and there is airway narrowing is there may be focal areas of low attenuation which is exaggerated in the expiratory CT, which is probably due to the airway disease. In case of small vessel disease, the airway are not involved when you do an expiratory scan. So the low attenuation areas persist with no exaggeration of the low attenuation areas. So that's why we do an expiratory HRCT in cases of mosaic attenuation. The other main indication in expiratory HRCT is in case with the ground glass appearance, where if you see some areas of ground glass expiratory air trapping in patients with ground glass, it can be due to hypersensitivity pneumonitis. Expiratory air trapping is not seen with UIP pattern in idiopathic pulmonary fibrosis. So there also it is helpful. So if the patient is not very sick and they are able comfortable and they are stable, then it is advisable always to do an expiratory HRCT to evaluate small airway disease. So any case with the small airway disease like bronchial asthma or bronchiolitis can show expiratory air trapping, which is an important finding in HRCT of the chest.
Thank you. There is a query regarding a difference between fibrotic and cellular NSIP.
Yeah. So there are two types of NSIP. Yeah. One is the cellular and the fibrotic. So the cellular is the preliminary form or the initial form where you get just ground glass appearance and where there is no evidence of fibrosis in the initial stages. So that is called the cellular form, where you can see here patchy areas of ground glass opacification are seen with subpleural sparing. So this is a cellular form of NSIP pattern.
And it is a reversible phenomenon.
Yeah, it may be potentially reversible. But this is actually this patient after follow-up 8 years later, this showed a significant improvement in the ground glass, but this has progressed to a fibrosing. So this is called as a fibrostic form of NSIP pattern. So whenever you get the early pattern with ground glassing in an NSIP pattern in the early stages with subpleural sparing, this can be called as an NSIP pattern, which is probably a cellular form. This possibility of cellular form of NSIP can be raised, and this is typical NSIP pattern with fibrotic pattern.
Dr. Babu, I don't know whether this question can be included in this session. Slightly out of context, there are 2 or 3 queries regarding how to kind of explain the COVID scores. How do you calculate the COVID scores? So, I mean, what I can say is we can have a separate day talk on COVID.
Yes, sir. There is also a controversial one.
Yeah.
So we don't include in this presentation.
Yeah. So we'll have a separate talk on COVID radiology findings and everything. And one was other questions regarding bronchiectasis and emphysema. Again, let me tell the attendees that we'll have a separate session on airway diseases, both large airway and small airway diseases. So I'm sure we'll cover it then. So that was all. Dr. Babu, thank you so much for the